Council of Governors meeting. I am very conscious that this is Meg Lambert's last board and Council of Governors meeting with us. Meg has been with us, I think, since 2007 and was the person who led South Warwickshire NHS Trust through the process of becoming a foundation trust. So Meg is disappearing for a new life in France. So Meg, you leave with all of our best wishes. I know you need to leave today's meeting early today, which is why I'm saying these comments now. But thank you very, very much, Meg, for all of your hard work over the years. Mary, is there anything you want to add to that just before I keep us moving on?
Yeah, so I'd like to repeat what I actually said at the pre-meeting for the sake of the minutes, is that we want to thank you, Meth, for everything. I've been a governor for a long time and you've been absolutely fantastic. You've been great support. And whenever I needed anything, you've always been there to help. And I'm sure all the governors would echo that. So thank you very much, Meg, and we wish you all the very, very best. And hope you have a happy time in France. We're going to miss you. We really will. Thank you.
Thanks very much. That's very kind.
Michael, your hand is raised. Do you want to say something and then we'll move on?
I started as a shadow governor, so I was there, and I would add everything. I don't know what I would have done without Meg. I wouldn't have joined most meetings because she still has to send me the link now.
That's great. Well, thank you. And thank you, Meg. So we've got a pretty full agenda, Council and members of the public. So we'll keep things moving forward. In terms of apologies for absence, we have apologies from Callie Harrison, Pram Jill, who is our new non-executive director from Warwick Medical School, Richard Colley, who again is one of our new non-executive directors, who is going to become chair of audit in the future, Julie Bell and Fiona Burton, who has had a burst appendix, bless her. So Fiona, we send you our best wishes for speedy recovery, and members of the public may not be aware that Glenn Burley, our chief executive, is still testing positive with COVID, but has bravely joined us again today to keep his 12-year record of not having a day of absence intact. So any declarations of qualification for office or declarations of interests which we should be aware of? Please raise a digital hand. Okay, I can't see any raised, so we'll duly move on. So the last set of the minutes held on the 10th of February. If you've got any points of accuracy, could you please raise a digital hand so they can be duly noted? Otherwise, I'll take them as accurate and I will assign them. Okay, thank you. So I can't see a raised hand. So we did have one action point arising, which was to circulate the national job description and details of the training for the patient safety partner once they were received. That action was with Fiona, and I'm not, obviously with Fiona not being aware, I'm not sure if it was circulated. If it was not circulated, we will make sure it is over the next week, so apologies for that.
It hasn't been circulated, Russell.
Okay, thank you, Mary. So Meg, if you can make sure that it is, that would be helpful, please.
I think the question was whether we received it, because there was some delay in issuing it at a national level. I'm not sure if Ellie knows at all.
Ellie, do you know?
No, I haven't had an update, I'm afraid, no.
Okay, so thanks, Ellie. We'll circulate an update as to whether we've received it so that we can circulate it or not, but we'll do that within the week, so apologies for that. We were due then to have the new non-executive directors introducing themselves, but I've already sent apologies from two of them. But I'm delighted that Phil Gilbert is with us. So Phil, do you want to come on screen and just briefly introduce yourself to Council of Governor colleagues?
Yep, afternoon everybody. So Phil Gilbert, I'm a director at E.ON and I'm currently responsible for integrating Empower and E.ON together. I'm married, I live in Solihull, and I've got 2 young children who are aged 6 and 4. And I've been in post for 2.5 months now, so I've been immersing myself in Swift and everything around it. So one-to-ones with board colleagues, the board meetings, first committee, and the best bit was I spent some time looking at our new endoscopy suite and understanding what that does and how that works. And then this week I spent a couple of hours on the nickel ward to find out what was going on in the community nursing world. So it's been great, and thank you for the opportunity to play my part, and I look forward to the next 2 and a bit years.
No, great, Phil, and really good to have you on board. And I know you've been working very hard to get your induction going and to be able to add value, which I'm absolutely certain you will as a NED going forwards. Now, I think you're our youngest NED, so hopefully you'll outlive the rest of us. So great to have you on board. I will ensure that the other non-execs attend the next monthly update with me and the NEDs and introduce them at that session for those governors who are on the call. So I think then, colleagues, we're on to the assurance items, and the first is the Ockenden report. The Ockenden report, I've got Linda Ward down as talking to this, but I can't see Linda on the line. Ellie, are you going to?
A minute ago.
Mia.
There she is.
Sorry.
Hello.
Oh, yeah, I can see you now. I apologise, my fault. So, Linda, do you want to give us an update, please, on the Ockenden report?
Yeah, happy to. Thank you. My name's Lynn Ward. I'm the Interim Associate Director of Midwifery for Swift. I will take the report as read, so I just wanted to highlight a few things for give you an assurance update. So I do hope that the report provides assurance that our maternity services at Swift have the appropriate oversight and governance arrangements in place to robustly monitor and triangulate a safe, effective, caring, responsive and well-led service in response to the Donna Ockenden report and the 15 immediate essential safety actions. The Ockenden final report from the independent review of maternity services at the Shrewsbury and Telford Hospital NHS Trust was published on the 30th of March. Donna Ockenden and her team have set out the terrible failings suffered by families at what should have been the most special time of their lives. There is an immediate call to action for all commissioners and providers of maternity and neonatal services who need to ensure lessons are rapidly learnt and service improvements for women and babies and their families are driven forward as quickly as possible. The final published Ockenden report was taken to the Trust Public Board on May the 4th, and it has been shared now with all relevant staff. Swift Maternity Service is absolutely committed and will take any action to mitigate any risks identified, and we have developed robust action plans against all the areas where our service do need to make some changes, paying particular attention to the report's 4 key pillars. They are safe staffing levels, a well-trained workforce, learning from incidents and listening to our families. We are busy at the moment submitting our compliance to the identified 15 safety actions to the Trust Board in June, and we will also be sharing this with the integrated care system and the local maternity neonatal system. On April the 5th, we were one of the first trusts to have a Ockenden Insight visit from the regional team. This visit was very successful and the team commented that they felt assured we were providing a safe service for women and their families. They commended us on our open and honest culture, our strong leadership strategy, and how our incident reporting mechanisms were very well embedded. They also commended us with our work we do with our neonatal partners. We also have some points of recommendations to action, and these are all included in our Ockenden action plan. To provide you with assurance around our safe staffing, a workforce review took place last December to ensure that safe staffing levels were being achieved following a large vacancy rate we had last summer. This has shown a significant staffing deficit due to the increased activity and acuity that we've been seeing in our services constantly from 2018. This has resulted in the recommendation of writing business cases, as the workforce investment being asked for is around 1.4 million. The first 2 business cases have been approved at Planning Board and are going to Management Board at the end of this month. NHS Improvement has also been supporting us into a deep dive into our compliance with Saving Babies' Lives version 2. An action plan's been completed against the gap analysis, and we do have several areas of work that need to be embedded, but we've now established a consultant Saving Babies' Lives lead and a Saving Babies' Lives lead midwife, which is one of the safety actions for Ockenden. The final Ockenden report does build on the 7 immediate essential actions that were identified in the interim report, and then outlines an additional 8 immediate essential actions. A template's been circulated, and this will help us build a gap analysis and a more detailed action plan in areas where work is required to improve safety in our services. On an initial review, there are additional aspects to each immediate essential action where work will be required to ensure full compliance. The multidisciplinary team is working together really closely to pull all these strands from the original report and the final report and from our assurance visit to ensure a comprehensive action plan is put in place so we can embed all the actions to be compliant. Work at Ockenden continues with monthly meetings with our whole MDT to work through this action plan. We are making significant progress completing actions at each meeting and identifying priorities for work. Most direct patient safety actions have already been completed, and most outstanding are the reporting, process and data actions. Last year under Ockenden, the funding under Ockenden had to be applied for by providers, and this year it's been sent to our clinical commissioning group to add into the baseline of providers. Coventry and Warwickshire LMNS have been allocated 1.5 million. We are currently working with the LMNS to consider the methodology on how this funding is going to be shared. As a provider, we will have been asked to consider how this allocation can be equitably shared, considering the following: transformation work that we already have in progress, our Ockenden and Kirkup outcomes, the delivery of the equity and equality agenda, and the implementation of continuity of carer. I'm happy to take any questions.
Thank you, Linda. That's a very comprehensive summary. But just on that last point about the level of funding that's been allocated to the system, clearly in total it's 1.5 million, and just our share alone would be 1.4 million. So the issue of central support for the implementation of Ockenden is a real issue, as is the national shortage of midwives. Ellie, is there anything you'd like to add to Linda's summary?
I'd probably just like to embarrass Lynn a little bit by saying that a lot of the positive feedback from the visit was around leadership and how the team felt listened to, and the work that Lynn has actually done in terms of safe staffing, etc., and the improvements she's made since she's been in post. They were very impressed with that. So thank you, Lynn.
Thanks,
Ellie.
Glenn, as Chief Executive, anything you would like to add on this very important issue?
I think just to recognise that there's always an opportunity to learn from events that happen in other parts of the NHS, and actually it goes beyond just maternity services. Actually, when you look at the cultural issues and safety issues that came out of Shrewsbury and Telford, so we'll always look at reports like that and find opportunities for us to do better. I think it's really important that the NHS doesn't use this as an exercise to just look at some actions, decide they're implemented, and then turn around and look in another direction. I think maternity services are by far the highest risk specialty in the whole NHS. So we have to have a continuous safety culture, and we have to have a continuous channel of listening to staff and to mothers and families about any concerns. So I think this, for me, is not an exercise of declaring compliance. It's an ongoing reminder of the need to have a proper safety culture in the service.
Thanks, Glenn. And as we have mentioned many times at board, arguably the two most important things we do as an organisation is to bring life safely into the world and help life leave this world with dignity. So questions or perspectives? Jane Knight, please.
Yes, I just wondered if it would be possible when we're having a training session at one or other of our meetings whether we could have a session on how babies, not how babies are born, but it's nearly 60 years since I was giving birth. And I think the priorities for C-sections and home births and so on has probably changed since those days. And it would be really interesting to have an up-to-date understanding of what the priorities on that can be, because I just heard that my niece is likely to have a cesarean anytime now, and my heart dropped. I thought, oh dear, is this a good thing? It just helped to know a bit more about what is good and what isn't. Maybe everyone else knows, but if they don't, I'd like us to have a session. Thank you.
Okay, Jane, I'm sure Mary through the GPC will put that on the list of training issues.
Thank you.
At its simplest, if you look at the OECD infant mortality rates, those countries who don't do C-sections or have a very low ability to do C-sections, for example, India, the infant mortality rates are very, very high. But going back to your comment, I don't think the actual mechanics of childbirth has changed that much. Mary Malloy?
Yes, Jane, I'll make a note of that. But I was going to ask if, when you've done the progress report on the immediate essential actions, and once it's been to the board, could the governors have sight of that? And we could see it at the board, but could it perhaps formally come back to the next Council of Governors?
That's really fine, Mary. We'll make sure that happens.
Thank you.
And Jean?
When I worked in Coventry, we looked at the perinatal deaths and issues relating to maternity. And what we did with, and perhaps with your little bit of money, is we did a retrospective audit over 12 months with a consultant and a researcher. And we went through every set of notes for the last 12 months and came up with 3 headings, targets that we thought were issues, and as a result of that, actually breastfeeding increased by about 40%, and issues to do with health inequalities and smoking. There was a huge focus on all the things that we identified, or the consultant and the researcher identified, and it was taken up across the city as a whole, with maternity obviously leading on it. But it really made a measurable difference. So I don't know whether that would be worth looking at.
That's helpful, Jean, and I'm sure that the team will try and dig it out. And there is definitely a national issue of a national significant shortage of midwives, which must be addressed. John Egan, please.
I noticed in reading the reports of the Ockenden report that the hospital, the maternity unit, had another set of objectives other than patient safety. They were concerned with natural birth statistics, that they wanted to achieve a certain level of national certain level of natural births. Do you have any sort of regular way of understanding from sort of junior management if there are any impositions on them which would in any way compromise patient safety?
Thanks, John. Glenn will come in and no doubt talk about the fact that in the past we were unpopular with our caesarean section high rates, which we did for patient safety. Glenn?
Yeah, I was going to say just that. I mean, this refers really to a national policy, which was to encourage natural births and to frown upon units that had high caesarean section rates, and we traditionally had a high rate, and so in certainly all the years that I've been here, there have been questions asked about whether we could reduce those rates. What we've seen locally is an appropriate clinical response to that from midwives and obstetricians, which is being that we will do what is safe and appropriate So we didn't respond to that challenge in the way that it would appear that Shrewsbury and Telford did. And I think there's probably just something here about an organisation like Shrewsbury and Telford, who are under a bit of pressure for a range of things, feeling that they should succumb to those kind of external pressures and comply rather than doing what's clinically right. And I would like to think in our organisation, because we have a better reputation with our regulators, we are able to stand our ground in areas where we think we should be appropriately led by clinicians on this. So I don't think I can think of many other examples around the NHS where there's a kind of push to achieve a different set of numbers. We do monitor our cesarean section rate. We're certainly not now suggesting that we're moving to any kind of target to reduce that, but it's an important one to get the balance right, because obviously if you can have natural birth, then that's the best thing to do. But obviously there are lots of factors that lead to a cesarean being the right course of action for individual patients. So I think I don't think, certainly not from board level and not from any of our operational managers, there is a kind of push to, if that's the right word, a push to implement some standards that go against what would be best clinical practice.
John, you put your hand down again. Did that answer your question?
Well, more or less, except in aviation circles, what they try to do is to make sure that the key people, especially the pilots, have had nothing forced on them other than safety. So is there anything going on that compromises patient safety being the number one priority? Is there a way of interrogating to constantly make sure that is the case?
I think there is, John, but if I use your airline analogy, a plane can't take off, a passenger plane can't take off without a pilot and without a second in command. The plane would not take off. The issue on childbirth, to be honest, is the population decides whether it's going to get pregnant, and those babies are coming. And being very practical, the issue is there aren't enough midwives, and therefore there is a challenge. And Linda referred to, we've done a lot of recruitment in the last 6 months, but we still need to do more. But the practical issue on childbirth is babies are going to arrive, and if there aren't enough midwives, you're therefore balancing risk, and that's a reality. And I think what Glenn, Linda and Ellie have said is, in terms of the way we balance risk and the decisions we've made, our priority is absolutely the safe delivery of a baby. And if other things are deprioritised, like continuity of care, the priority will be the safe delivery of babies. I will come to you in just a second, Andy, but Glenn, did you want to add anything to that?
Just specific answer to John's question. There's a question in the staff survey that is asked of every single member of staff, that is patient safety the trust's number one priority, and we perform very well on that compared to peers, and I'll dig out the answer so I can give you the specifics on it.
And Andy Petros. Andy.
Thanks, Russell. A couple of questions. I was just wondering, at a local level, apart from, say, going to PALS, what are the mechanisms for mothers and perhaps indeed fathers to give feedback, for want of a better term, complaints about their experience? Obviously, they can go to PALS, but how open are we to it? I mean, is there a website? Are there boxes on the ward? How easy is it for a mother to feel, perhaps anonymously, even give feedback? And then the second part of that question is, what are our rates of not necessarily complaints?
At a time. Can we do one question at a time?
All right. Okay.
So, Linda, on that question about mothers and potentially fathers being able to give feedback, do you just want to brief us all on the processes we use?
Yeah, absolutely. Yeah, we obviously have PALS, but we also work really closely with the Maternity Voices Partnership, which is it's set up just for mothers and fathers to give all their feedback, and that we meet with the MVP really often, and they come to our LMNS boards. I have a really good relationship with the chair, Leanne, for Coventry and Warwickshire, so we get a lot of feedback from there. We have our social media groups where all of our women are welcome to leave positive feedback as well as anything that we can improve on. They have really good relationships with our practice team midwives, so they often, if there's any concerns there, it will come through the practice team midwife. If there's nothing that the practice team midwives feel that they can't sort out, they will escalate it to a line manager or to one of the senior leadership teams. So we do really encourage all kinds of feedback. Obviously, we don't like getting complaints, but that's the only way that we learn. So we have a small number of formal complaints, but it's only a very small number, but we have a lot of positive complaints. So yes, so social media, I Want Great Care, PALS, talking to the midwives, and also we reach out to fathers as well. So there's lots of different forums, and we have our different social media groups, like our infant feeding groups and our quality improvement groups for maternity. So there's lots of different ways they can reach us for us to listen to them, so we can improve our service.
Thanks, Linda. And quickly, Ellie, before I allow Andy to come in with this.
I'm just going to say, yes, we proactively seek feedback for all our services, including maternity, not just when there's a problem. But the other thing that we do in all our services, as well as maternity, particularly if we know that there is an issue, rather than wait for a form to complaint to come in. So if things haven't gone as well as they should, we reach out to those parents as soon as we can, and we include them with any investigations or with any outcomes, and we keep them close, don't we, Lynn? If there is an issue, we know that. Yeah.
And Andy, sorry to interrupt you, but your second question just.
No, thank you for doing so, because that answered my second question as well. Thank you very much.
Okay, that's great. So a really good comprehensive discussion on what is a real issue. Just so members of the public and the Council of Governors are aware, we do know this. There are other issues which we need to help expectant mothers on. Colleagues may not be aware, and I think I'm correct in saying this, Linda, about a third of our expectant mothers are on some form of antidepressant drug regime, which is a quite astounding number. And the consequence of that is the implication on the amount of time they must stay in hospital with us, the way that baby is monitored when the baby is with us is very time consumptive. So as a society, we do, I think, need to ask ourselves some fundamental questions as to why a third of expectant mothers are on antidepressant drug regimes. We will come back to this issue, colleagues, because the Rockington report was a horrifying report. The UK has the 27th worst infant mortality rate out of 38 OECD countries. We must, as a nation, do better in making sure babies are delivered safely and life is preserved. So we will come back to this, and it is definitely a very significant priority for the board. We'll move on then to the recovery of elective services post-COVID. Harkamel, do you want to lead us on this, please?
Yeah, so I obviously gave a presentation at the roundtable, so many of you will know what the framework is. So I propose just to present a bit of an update on where we are so far, if that's okay. So I have obviously got a bit of a presentation. So just as a recap, the elective recovery rules and payments are slightly different this year to what they were last year. Last year we did quite well. This year the rules are really, really sticky and proving quite difficult. But fundamentally, we've got the opportunity to make just over 7 million on additional elective recovery. The target overall is 104%, but because we have to do significantly fewer follow-ups, that actually means 85% follow-ups and 109% of new day case and inpatient activity when compared with 1920. And I mentioned before, but advice and guidance is a new outpatient. and now worth around £15,000 a month for us in terms of income. So a really a stream sort of worth pursuing. As of this week, where we stand in terms of elective recovery, we now have 376 patients dated over 52 weeks. 25 of those are over 78 weeks, and of those 17 are undated. And we remain with no patients over 104 weeks or 2 years. I've included some graphs there just so that you can sort of see the profile and the significant reduction that we've made in terms of our long waiting profile. The 52-week profile you'll see started to increase, which we sort of expected, and is levelling off again. So that's certainly one to watch on the non-admitted side, I would suggest. The 78 weeks, we're still aiming to try and clear all of those by the end of June. Our virtual appointments for first and follow-ups remain above the target of 25%, and we're doing much better than a lot of our peers with that. So I'm really, really proud of our virtual outpatient work. And PIFU, we remain above the 1% target at 2.06%. I know that sounds like quite small numbers, but actually to try and speak to people and make them understand what patient-initiated follow-up means, and then switch them onto that, you know, that's going to be a bit of a slow burn, but it's certainly something that our clinicians are ready to engage with and quite eager to pursue. And it will just be a case of booking those patients in and carrying out that validation. So against the ERF, in terms of how we're looking... Yeah.
Can you go back to the previous slide?
This one?
Yeah, I love the pace. But just to make sure that everyone understands what a patient-initiated follow-up is, can you just explain that?
So a patient-initiated follow-up is where a patient has been referred by their GP, and they will have been seen by whichever consultant, and either after their first consultation or after their diagnostics, or indeed after their treatment, it may be appropriate to move that patient onto a patient-initiated follow-up. So this usually works for patients with long-term conditions, whereby they're on, I don't know, a complex regime of drugs under gastroenterology or rheumatology, for example. And it may be that we would historically have followed them up every 3 months or every 6 months just to check in. What a patient-initiated follow-up does is says to the patient, you tell us when you don't feel very well. So you don't have to go back to your GP, but we won't bring you back, you know, just to make sure you're doing okay. You let us know. And that tends to work really, really well for our patients who are on a long-term treatment plan, but are really good at managing their own conditions. But, you know, you wouldn't necessarily want them to go back to their GP and wait again to be seen. And this is just a direct route in. So as soon as they need a follow-up, we'll book them in. So it's hopefully a win-win, that for patients, they're not dragged in unnecessarily every 3 or 6 months, having to go through all the inconvenience of a day off work or having to get into the hospital. And for consultants, their time being taken up just by asking the question, how are you feeling? I feel fine, thank you. So hopefully it's a win-win on both sides. That's the objective and the purpose. Sorry to interrupt you, Harkamel, but we all get locked into using abbreviations and acronyms, and they confuse me. We do, sorry. It's remarkable how quickly that happens to you, isn't it? So in April, so I explained at the beginning around the elective recovery rules. So we're aiming for 109% for new day case and inpatient. And April overall was a challenging month for us. We did do very well on the inpatient work. So we achieved 101% of what we did in 1920. And I just want to remind everyone that in 1920, as we are now, back then we were an organisation who were churning out a significant amount of work. We were and remain the benchmark for a number of organisations, certainly in the system, to try and achieve what we achieve in terms of productivity and efficiency. So when we're comparing ourselves now, we are comparing ourselves with the Swift of a time when we were doing a lot of work. So this was always going to be a much harder challenge, I'd say, for us than some other organisations. We didn't overperform on follow-ups, which is good. So we wouldn't have got paid for anything over 85%, and we achieved 81%. But we didn't do enough outpatient first appointments or day cases. So overall, we're still sort of validating the position and making sure that everything is coded. But I think it goes to show just how challenging this set of rules are. And so we kind of continue to try and work through them and make sure that we understand them and, you know, negotiate to see if there's anything that we can sort of do about them. So overall, we landed where I would have expected in terms of not necessarily achieving the 104% overall, but there are still sort of green shoots in there. And I think notably to maintain 101% of inpatient work against the backdrop of a very busy organisation in terms of emergency pressures is sort of no mean feat. So that was it from me.
That's great, Harknell. Just on that last point and on that last sort of few slides, just for Governor colleagues, Swift has for a number of years under Glenn's stewardship been one of the most productive and efficient NHS trusts. And one of the, as quite often happens, the centre sets a blanket number, in this case 104%. So if you weren't very efficient before in 2019, you should easily be able to achieve that. If you were very efficient, such as us, it's more of a challenge. So it's just worth contextualising that point. Any questions or perspectives to Harknell? I can't see any digital hands raised. Harknell, I've said it on a number of occasions, you're doing a great job for us. And just carry on doing what you're doing. The level of commitment, drive and innovation you're pushing through is fantastic, and it's great to see.
Thank you.
Okay, colleagues, we'll move on. You can give me the fiver later, Harknell. We'll move on then to the quarterly status update report for Q4, just finishing off last financial year. Glenn?
Thank you, Chairman. So this is the report that you're obviously there's some new governors on this call, but comes to every council of governors meeting and looks back on the compliance with the objectives that we jointly agreed over the course of the year. So we look at that on a quarterly basis. This is the wash-up report for Q4 of last financial year. Obviously, the financial year ended at the end of March. Those of you who follow the board papers will have seen this has also gone through the board, and it will feature in our annual report as we look back on the year just ended. The objectives that are set for the trust each year are set in collaboration with governors, and that's why we have our roundtable events. We've obviously recently set a new set of objectives for the year that we're now in. So this is a little bit of a look back. What we also try to do with our objectives, though, is ensure that there's a number that are quite stretching, as well as progressing our strategy. So I rarely expect to see everything green, and if everything's green, then I probably reflect that we haven't been stretching enough. So if you look across the year just ended, there's 4 areas where we've gone amber rather than green. There aren't any reds, so there's progress in all the areas that we set out. And I'll just talk you through the amber areas quickly, if I may. So firstly, there's the one about improving tertiary access, and we've been in discussion throughout the year with colleagues at UHCW. Those conversations are still ongoing. There's still, in my view, a particular concern around oncology capacity and consultant recruitment, and we will still push UHCW to improve that. One of the areas that we have seen an improvement on is around interventional radiology, which was previously a service that we accessed UHCW for, and we've recently. The other thing I should say before I start talking is the builders are in as well as having to work from home. The builders are in, so if you hear drilling, there is drilling going on in the background. The interventional radiology, we've recruited our own person on that, so that's improved dramatically. There's then an area on the new urgent care model, and whilst we continue to improve the flow in urgent care, one of the specifics that we were looking at around this objective was the minor injuries unit at Stratford on Avon. We temporarily closed the minor injuries unit in response to COVID, which allowed us to move some of our staff to concentrate on the Warwick site. We have stated that we'll reopen minor injuries unit, but we are also looking at a future service model that needs to be compliant with the new national guidelines. In order to be compliant with new national guidelines, you need to have medical cover in a unit like that, whether it comes from a GP or whether it comes from consultants or other junior doctors. At the moment, we haven't got medical cover. So that forward look review will have to consider whether that's something we can or should do at Stratford. Meanwhile, we will reopen. There's then an action around Foundation Group Informatics. We've been doing quite a lot of work on this. We move from August to having a quarterly meeting of all 3 boards in parallel, which will allow us to do more benchmarking of performance between the 3 trusts in the group. And in the background leading up to that, we've been trying to ensure that we're comparing apples with apples on our performance charts to make sure that the counting and coding is the same, and also to agree some of the things we're going to benchmark in that meeting. So we're looking forward to that meeting getting up and running. There was also, though, some work associated with informatics support around population health management. And we still haven't resolved some of the concerns around information governance that are coming from primary care colleagues. So that's why we decided to put that one as an amber. And then finally, there's some work on health inequalities. You may well have seen that a week or so ago, we launched our Levelling Up report on the health inequalities, which I think is excellent. Really good video alongside it, and the report went through to board. That sets out the areas where we will aim to focus on improving the outcomes for our communities over the coming years. So that's a really good piece of work. And alongside that, a piece of work around developing financial model for population health management, which we didn't conclude during last year, hence that one's amber. All other areas were assessed as green, and there's been some really good progress, despite what you could say is quite a number of other things going on that were challenging for particularly the senior team. So it's good to see strategic progress as well as a really good response to COVID. So as soon as I stop talking, they'll stop drilling, you can guarantee that, but I'm happy to take any questions.
Thank you, Glenn, and we can't hear the drilling. Any questions or perspectives to Glenn? Mary?
Yes, Glenn, thanks for that. Can you tell me the ongoing development work on the delivery of urgent treatment centre? Can you tell me what the thinking is on that?
Yeah, so it's that question that I just touched on, which is so minor injuries units. If you look at the national strategy,
it's not a separate centre from the minor injuries unit. It's one and the same thing.
Yeah, so we need the so you can't have minor injuries units anymore because there's no definition for them. So if we had a facility in Stratford into the future, it would have to be an urgent treatment centre or an A&E.
Yeah. Thank you. I thought it was 2 separate things. Okay.
And any other questions to Glenn? Okay, thanks, Glenn. We'll come back to other sort of topics later on in the agenda. Mary, if you could take your hand down, that would be helpful. Thank you.
Right.
So the patient experience assurance report, we don't have one this month. The next meeting is due next report is due in June, so that will come back to the September meeting. I forgot to say under the apologies that Dr. David Spraggart sends his apologies as today is a clinical day for him. So on his clinical governance assurance report, I'll take that as read. Are there any questions on the clinical governance assurance report? It's obviously a very busy time as we do come out of COVID and we ensure we get back to the standards of 2018-19 and don't accept anything like second best. Okay, so we'll move on then. Thank you. So Kim, in terms of the finance assurance report, over to you, please. Okay, Kim doesn't appear to be on the line, Glenn. I'm going to drop you in it at this point, as I always delegate upwards. In terms of the finance assurance report, Glenn.
Yeah, I wasn't expecting to do this one, but I'll do it, Chairman, because it's like going back to my roots. So firstly, looking back on the year just ended, obviously we're producing annual reports and annual accounts on this. In summary, we delivered against the planned break-even position that for the organisation. In previous years, we've delivered bigger surpluses, but the way that finances worked over last year meant that we were given enough money to cover the costs of COVID and no more. For many trusts, that meant that they went into deficit, actually, so we didn't go into deficit. But what we have done is change the accounting treatment of our IT assets. They're now revenue items rather than capital items. So what you will see is a technical adjustment to our accounts, which will show a deficit position, but it's not a deficit position that we need to worry about. It's one that we've cleared with our external auditors and our regional team, and to all intents and purposes, we met our financial duties. We're obviously into a new financial year, and this financial year is very challenging, and with all the assumptions that we've been asked to make around a level of inflation and a level of ongoing COVID costs, we are again setting out a plan which doesn't deliver a deficit position for our organisation. And I'm conscious many on this call will not be so familiar with NHS finances, but suffice to say, we're the only acute provider in the whole of the Midlands who isn't in deficit at the moment, is probably an example of some of the stresses and strains that are going on at the moment. So we have a challenging plan for this year, which will deliver a small surplus. So that's probably it in summary, Russell. If I was to talk about an area that I think we need to focus on, it would be around what we saw quite an increase in agency and bank costs towards the end of last year. Obviously, we've seen higher sickness levels than we've ever experienced associated with COVID. So we moved from 6.5 million to around a 10 million spend on agency, and that's something that we can see falling now, but needs attention to make sure that doesn't become a concern, because agency staff are not only expensive, they're not as good as substantive staff. So there's a quality and financial issue there to address. That's probably all I would say.
And just before I invite questions, I understand there was a bit of a discussion at a meeting the other night, which I wasn't at, about the level of productivity improvement we expect and efficiency improvement we expect. And we obviously have what we call a CPIP target, which is around 3%. But I think it would be helpful, Glenn, if you just sort of described in a bit more detail how that isn't just the level of productivity improvement we expect to see. Harkemel's been talking about a 4%, 104% of 2019 activity. So can you just describe why, when we're talking about CPIPs, it's not all of the productivity benefits that we push for as an organisation?
Yeah, so the way that they calculate the amount of money that are given to NHS trusts is they make an assumption that we will deliver a level of cost of cash releasing efficiency savings, as well as they make an assumption around a level of inflation. And so they give us what's called a tariff deflator or inflator. So they take a net position in all of that. If you believe the national numbers, then they only ask us to make about a 2% efficiency saving. But actually, when you look at what we're given, that often results in a figure twice that. So that's why we're talking about a 4% level. But that's really just the kind of cash on cash position. Alongside all of that, there are huge increases in demand in most services each year. So we're generally doing more for that money, as well as having to deliver a cash releasing efficiency saving. One of the big ways that we'll do that this year will be through the elective recovery fund that Harkemel just referred to. So we are in a good place on our local waiting times. Elsewhere, and particularly near to us, there are some real problems with waiting times at University Hospitals Birmingham, University Hospitals Leicester, our colleagues in Wye Valley and in Worcestershire. So we are offering what we call mutual aid taking patients from their waiting list and treating them more rapidly than they would get local treatment, and that brings more income into the organisation. So that's part of the way that we will deliver that net efficiency saving will be to get some money for doing additional work for other commissioners.
That's great, Glenn. Questions and perspectives, Jean?
Obviously, I'm not like Roger or yourself in terms of knowledge and experience on finance. But when I read the various reports, it looks like we're being impacted on financially by UHCW's difference from us. And yet when I listen to today, that doesn't sound like it's the case, that we seem to be standing alone in able to act independently to show that we're doing better than some trusts. Which is it, or is it both?
Well, firstly, I would say we're doing better than most trusts, but we could be doing a lot better if we were still under the old financial regime, which paid you for the level of activity that you do at a standard national cost. So the current regime has moved more money to organisations that are spending more money. We talked earlier about the Ockenden funding. So, for example, the £1.5 million that's being given to the system for Ockenden, there's a bit of a process of bidding for that rather than it being given to organisations based on a fair shares allocation. So I think if you look at system finances now, there's been a little bit of money skewed towards those organisations that are in deficit to try and reduce their deficits. And that's why we're no longer making a surplus, but we're holding a break-even position. So if we went back to the old PBR rules, payment by results rules, we would definitely be still making quite a sizable surplus.
Thank you, Glenn. And it is one of the things that worries me about the current financing regime is there isn't enough incentives in it. Sue?
Yes, please. Could I just ask you about CIPs or efficiency savings? I understand what you say about recovering some of the money by extra activity, and that's great. But I know that, and it has been for some years, and I'm sure in most trusts, the CIPs made have been non-recurring. And excuse me, I'm not a finance person, as you know, but that if it's non-recurring, then surely that will be rolled forward to the next year to be made a saving. And how long can you keep rolling forward until the savings you have to make are bigger than your income?
Not a finance person, but what a good question. So yeah, and I think that's a feature of many trusts now, that their cost improvement programs have become very non-recurrent. Obviously there's a recurrent element of this, but yes, what it means is if you only make them as in a non-recurrent way in year, then but when you start a new year, you have to start all over again with that challenge. But the nature of the way that the NHS finances are working mean that we do have this rather strange kind of reset of our income each year based on our expenditure. So it's probably less relevant now, the recurrent non-recurrent bit, than it was a few years ago, where we knew we had a tariff and we knew it was activity based. So I'm not overly concerned about it. Obviously, we compare favourably to all the other acute providers in the system. But yeah, it would be far better if those savings were recurrent rather than non-recurrent. But we have a very innovative group of staff, you included, who come up with ideas that allow us to deliver that program. So I think we're doing quite well on that. That's why I'm looking more to income this year from the elective recovery fund than I perhaps would have otherwise.
Thank you very much.
Thanks, Sue. Thanks, Glenn. And Roger?
Thank you. Glenn, the perennial problem of capital allocations. We managed to come in just under our capital budget this year, despite delivering all sorts of things, not least the car park. I'm wondering, in view of the ambitious plans and necessary maintenance work that has to be done at Warwick, how we're getting on with securing funding to be able to initiate that type of renovation and regeneration.
Glenn, you're on mute.
Schoolboy error. Sorry, it's a worry, Roger. The amount of capital that we're allowed to spend this year is around £13 million. You will have seen our estates report, which showed that we probably need to spend in order of about £75 million in order to address some of the backlog maintenance and improve the estate in the way that we'd like to. Prior to the last couple of years, we had full freedom as a foundation trust to spend capital as long as we had the cash for it. But now, even if we have the cash for it, we have to fit within this ceiling in order to avoid the whole of the NHS overspending its capital allocation. So it is frustrating, and it does mean we go into bat with colleagues in the system about whose backlog maintenance problem is bigger than the other person's. What we're doing in order to try and address that is looking for alternative sources of finance, potentially things that are off balance sheet. David Moon, our strategic financial advisor, has got a couple of ideas on that one that we're looking at carefully. But what we've also got to ensure is that, yes, it will be great if we get them out of that constrained allocation. We've got to ensure that we're spending public money wisely and we're achieving value as well. So it's got to meet both tests for me, and when it does, you'll see it. And I hope we get to that point. But yeah, we simply do not have the capital spending allowance this year to do everything that we want to do. So it's a tricky scenario. That's it. But we still have cash in the bank, so that's the frustration for us, that we could spend more if we were allowed to.
Yeah, I mean, this is a broader issue than just for us. But I would make the point that the great dangers to the way the capital allocation is working at the moment is it rewards those organisations who haven't invested in productivity in the past and aren't as efficient as us. It seems self-evident to me that those organisations that are the most productive and most efficient should be those encouraged to invest more and given the funds to invest more to become even more efficient and productive. And finally, Jean, and then we'll move on.
Just to say, I remember the day when I used to walk around the hospitals with the chief exec, making a huge, great big list and encouraging people to spend money. And we actually did tarmac the netball court just so that we spent enough money to make sure we got enough money in the following year.
And that's great. I'm not sure the netball court exists anymore, Jean, but anyway, so moving on. Thank you, Glenn, for covering all of that. We'll move on then to the audit assurance report. Rosemary?
Right. Good afternoon, everyone. And for those who haven't met me before, new governors, I chair the audit committee and have been chairing the audit committee for the last 8 years. I'll take the papers as read, but just bring out a couple of points. We're at sort of year-end time for the audit committee. So at our last meeting, we met with the internal auditors. They gave us their annual audit opinion, which was one of significant assurance over the controls of the organisation. And that obviously gives governors comfort that in general systems and controls over the risk of the organisation are working well. And that will feed into the annual report. We also had similar positive assurance on the board assurance framework, which is how we govern the principal risks of the trust. The one point of concern which I want just to highlight was that around patient access plans. So the audit committee, the internal auditors carried out a review of patient access plans some 2 years ago. but the impact of COVID, etc., meant that the recommendations were not implemented. So that is something which the Audit Committee are really wanting to focus on over the coming months, because having the patient access plans for those who are new to the organisation basically is having a plan in place for each person who's been seen first, who's been seen by the trust, and to set out their next stage of treatment. So it's really important that these are well managed, and that there's no gaps in the system. So that's something which we'll have a lot of keep focusing on over the current months. That's what I wanted to bring out. Any questions?
No, thank you, Rosemary, and thank you for dialing in remotely as well. Questions or perspectives to Rosemary? Roger?
Rosemary, a perennial one for Audit Committee is the digital standards. I can't remember the exact acronym for the security
data protection security toolkit.
Exactly that one. Are we going to be able to come up with a standards met for this year? Because it seems that just when people trusts understand what they've got to do and manage it, NHS Digital goes and adds another half dozen criteria just for the hell of it.
Yeah, okay, thanks for bringing that point up, Roger. And yes, it's when at our last meeting we were informed that the group anticipates meeting the standards. They have to sign off by I think it's the end of June, so a little while yet, but yes, from all the work that's been done so far, they believe they will be meeting the standards. And you're right that each year the goalposts do move as standards are raised on this, and rightly so. But yeah, we will be in a position to meet standards, yes.
In that case, I think everyone involved should be complimented, because I know how much effort has been put into trying to meet the uphill list of requirements.
Yeah, no, and I can say that the team are really proactive in that respect. So we've got a lot of assurance over the last year or so as to how much focus there is, and specifically around cyber security.
Okay, thank you, Roger. Thank you, Rosemary, and thank you for all your hard work. So we'll move on then to reports from representatives on projects and groups. And the first up is Mike on the Ellen Badger Hospital site redevelopment. Mike?
Thank you, Russell. So I've issued the paper, so I'll take that as read. Interesting update. There's talk there about Sophie meeting with the Stour Health and Wellbeing Partnership. She did that on Monday with Mark Rowlands, who's head of hotel services, who his team run the Health and Wellbeing Centre at Stratford, and Sophie's assistant director attended as well. That went really well. What they're really looking for is support on getting a pop-up hub, health and wellbeing hub, going before the building is finished and ready to move into, so that they're flying as soon as it opens. So that was a very productive meeting. Lots of, I think Karen's been met with on Wednesday next week. So it's good to see things actually physically happening in the community in advance of the physical building. So yeah, that's most up-to-date bit.
Okay, thank you very much, Mike. Obviously, real challenges in terms of building costs, given that this project has been delayed and there's quite extraordinary inflation going on building costs, which are not trivial and are affecting the whole costings on that project, which is requiring the board to understand the implications of that. Any questions to Mike? Thanks, Mike, for your diligence on that, because I know it's not an easy gig. We've then got the end of life committee. Michael, do you have anything to update us on this?
No, we haven't had a meeting since the 22nd of November because of pressure of other work on the members of that committee. It is, however, very important, and the meeting I did attend on that occasion, I was very pleased to be there and look forward to the next one, which will be on the 6th of June.
Okay, great, Michael. We look forward to an update next time, but a really important issue. As I said earlier in the discussion on Ockenden, the dignity that we show at end of life is one of the most important things we do. The Falls Group, I know there have been some issues on this. David, any update from you? Are you on mute if you're speaking, David?
There we are. Right. Yes, we had a meeting on Tuesday. It was the first one for quite some time. Generally, the falls data are improving. Year on year, there was a 8% decrease in falls and 18% decrease in injuries, which is really good. March to April, total falls dropped from 17 down to 9. One problem came from a junior doctor report from rehab, where it's reported that junior doctors in rehab are not necessarily following the falls protocol, which is disappointing. I will ask for an update on that at the next meeting. I raised the Stroke Falls project, which is proving difficult due to the need for volunteers, training, finance, etc. We had a long discussion and it was suggested that the outreach service could be utilised in the meantime. The suggestion was that someone from the service could attend at stroke access stroke meetings to discuss and arrange, if necessary, the services that are available. Whilst this is not the ideal one-on-one training service, it could be much more comprehensive. Any questions, please?
Thank you, David, and thank you, Jean, for deputising for David as and when. Any questions or perspectives to David? Okay, so we'll move on then. I don't think there's been a patient experience group. Jane, has there?
Yes, there has actually, earlier this month. And it was the first one for several months. So there was a pile of stuff in it. And I've got a list as long as your arm of all the things that they were talking about. So just to say, overall, it was very impressive how much work's been done and what's being done successfully. Just picking out of at random, the Hotel Services report had a 98% satisfaction on hygiene. The food survey showed that there was a high level of satisfaction and they're introducing electronic choice of food. So all sorts of interesting and positive stuff. There was also work being done on an ongoing thing, which is nighttime problems with noise and things. There's a high level of satisfaction from I Want Greater Care, but there were waiting times for eye treatment were too high. So there's a mixture of good and bad. Some people are having problems with the patient portal, but on the other hand, we've now got training with British Sign Language, and the volunteer section were particularly good because they volunteer for just about everything from breastfeeding to kissing it better to helping corpses look better before the families come to look at them, rehab for cardiac people. As I say, it's just a long list of good and bad and quite difficult to report on because there's so much of it. But anyway, that's where we're up to now, and you might be pleased to know I'm not on it anymore, apparently, so you can get someone else to do the report.
Okay, well, thank you, Jane, for being on it, and thank you for that update. Any questions or perspectives to Jane? Okay, great. And my mother always used to say, "I'll kiss it better," so that always brings back happy childhood memories. We then move on to the Patient Safety Surveillance Committee. Verbal update, Jean?
Yes, I can provide assurance. They're certainly thorough, and they certainly go through everything that needs that we're aware of. One of the things was they reported that the homeostasis and thrombosis committee are not meeting, so they'll be speaking to them because there are some issues that have been arising on that. Ambulance waits, obviously, but also EPMA, quite a lot of discussion about introducing that and what issues there might be that might provide hiccups in relation to that, but they're certainly on the ball in terms of looking at that. Falls and SIs, they're just really thorough. I can't fault them. Everything comes across their way and that they look at.
That's great. Thank you very much, Jean. Any questions or perspectives to Jean on the Patient Safety Surveillance Committee? Thank you, Jean, for your hard work. We'll move on then to the Patient Portal Group update. Pat?
Yes, well, the meeting scheduled for the 2nd of March was cancelled, and there's been no new date set yet.
Okay, so you'll update us after the next meeting you're able to attend, Pat?
Absolutely, yeah.
Thank you. Harkham or Glenn, I'm not sure if you know the numbers as to how many have signed up though to the patient portal, because it has been very popular.
Harkham might have a better stab at it.
Not off the top of my head, but I can find out. And
okay, if you can pop it in the chat box and then I'll just brief members of the public, that would be great. Thank you, Harkham. Thank you, Pat. And then the Safer Discharge Group, Jean?
Yes, that's also really proactive and doing a brilliant job. One of the things that they've been looking at is medication, which, as I said earlier, Mary has also been able to really assist on that. There's been moves on the medication to make sure that TTOs are provided on time and are correct. Correct is one of the issues. So there's now been a move to provide technicians for the two wards that have the most need, and that research project that study has started, and it's already showing success. It was mentioned in the meeting this week that perhaps it's a very small sample, but nevertheless, the sample shows that it's success. Whether the trust has got enough money and staff to provide that type of support across the board. But there's also been a move in the wards, whether it's because when you raise the profile of something, but medication errors have improved. So all the things that they're looking at are showing improvement, and where it isn't, they're looking into it. So I'm very impressed, and it's a very wide range of people who attend. So the contribution both in that and the patient safety surveillance means that across the trust, everybody that should be represented is represented. So, and they do attend. So it's as I say, I provide assurance, and it's impressive.
Thank you very much, Jean, and thank you for your assurance statements. Any questions to Jean on the Safer Discharge Group? I think there obviously is a general challenge. I think I'm correct in saying that 29% of our beds today have patients who are, using the old phraseology, medically fit for discharge, but we're not able to discharge them at the moment because of issues in terms of being able to get them safely home with social care. Questions or perspectives? John?
Have we still got our nursing home that you used to use? You used to use a, yes, is that full?
Yeah.
Yes.
John?
Is there any, I was really pursuing a similar thing to the last point. is there any purpose in actually trying to find a lower cost way of keeping people if they clearly a hospital, certainly one doing operations, must be the most expensive place in the world to keep a patient? Is there any purpose or any idea of having some lower cost system of keeping people instead of having them at the hospital?
Glenn,
I was thinking, for example, if you built something like a Premier Inn, you could keep them there, and it would be much cheaper than having them in a hospital.
Yeah.
Yeah. So yeah, in answer to the question, yes. I mean, so what Jean was referring to there was something called discharge to assess, which is a pathway of care which uses nursing homes, but also some of our community hospital beds to move patients from the acute setting as soon as their acute episode is over, but whilst they're waiting for other packages of care or assessment. And that's worked really well. Actually, it was when Number 10 released the Health and Social Care Bill press release last week, they quoted our discharge to assess scheme as one of those schemes that does that. In addition to that, recently we've also commissioned some additional domiciliary care capacity from an independent provider in Leicestershire, who are taking caseload away from our district nurses who have been holding patients who are waiting for domiciliary care, so that they could be freed up to either do admission avoidance or step patients down from hospital. So we're forever looking at those pathways, John, trying to find the most optimal way of doing it. Sometimes in some parts of the NHS it comes down to an argument about who should pay for what, because obviously there's the local authority elements of domiciliary care versus the NHS elements of domiciliary care versus the acute sector who are saying, well, we're here just to provide acute care. We ended up in a lot of arguments over a long time, and we decided that the best thing to do was for us to step in and provide some of that step down capacity for the reason that you described, because by freeing up the beds, we do the elective work and we receive income to do that. So we're pretty good at it, but I suppose all of the pathways I've just described make one assumption, that you can actually find the staff to deliver them. And the biggest problem still is that domiciliary care workers are a really challenging sector to employ people into. And we've done a little bit to adjust their pay rates recently, but we'll need to do more, and we'll need to make them more attractive roles than the somewhat easier jobs of going and working in a shop and getting paid more and having a 10% discount card and all those kind of things that go along with it. So it's a challenging area, but we are trying to innovate.
Yeah, there's a very comprehensive understanding, John, of the level of potential savings of putting people into the right place of care, which is best for them and cheapest. Roughly, we would be able to save as a system about £15 million a year if patients were in the right place. What stops that happening are two things, as Glenn's indicated. One is the staffing to get people home. That's why we've got 29% of our beds with people who shouldn't be in a hospital. And the second is the funding, because local authorities do not have sufficient funding to pay domiciliary care providers sufficient for them to be able to recruit the staff to do the work, to take the packages. So it's a very related problem, but relatively we have been at the forefront of these developments to try and what we call left shift, and we're very focused with our system colleagues on left shifting to lower cost setting. There's no doubt the cheapest place to deliver healthcare is in a house, in your home, and it's also where you are healthiest. Jean, did you want to come back in, or can we move on?
Yeah, well, just to quickly, UHCW, they looked after my sister-in-law who had a very dense stroke and lost mental capacity. And they did everything that you're supposed to do as part of the care pathway. And then they had planned her discharge to a nursing home that was quite a long way away. which would have created a lot of difficulties. And we managed to find our own bed place in an ERA establishment. She died just a few days later, but they arranged the discharge and she was going. So I'm just saying that there are other ways, I suppose, around it, but that's not very good for the patient or the family.
Exactly. It's like mental health services with people having to be put into facilities in totally different parts of the country. Glenn, your hand's still up. Is that legacy? Okie dokie, team. Thank you for that sort of updates from all of the working committees. We'll move on then to the trust name change and constitutional change. So I've just briefed governors on the pre-meet, but the background to this is with the development of our relationship with Warwick Medical School and the development of our research strategy and capability, we have had approval from the Department of Education with the support of the University of Warwick to change our name to include the word university. We've looked at different options. The option that's in the paper to the Council of Governors was Warwickshire University Foundation Trust. But as part of our engagement process, we have taken stakeholders' feedback. And that feedback has come from partners in the system, regional colleagues, but most importantly, our staff. And the general feeling is that we should retain the South in our name. And therefore, having discussed it as a board, the board is recommending to the Council of Governors that the name change becomes South Warwickshire University Foundation Trust. That has the advantage that we don't have to change our email addresses, that staff who have invested in Swift branding on various different things don't incur any costs, and that the benefits of the Swift brand, and it is a significant benefit because it is well known, are retained. We do recognise that clearly the geographical spread of Swift has for a number of years been westwards into Solihull and northwards into North Warwickshire. But given the feedback that we had, this is the new recommendation of the board. So I'll invite questions and I'll come to the need for a decision. Roger?
So you omitted in the new proposed name the initials NHS. Was that merely oversight on your part, or a genuine desire to have South Warwickshire University Foundation Trust, and that's it?
No, I think it was an oversight on my behalf.
So we must have NHS in the title.
In exactly the way we have at the moment, Roger. The NHS is the title at the moment.
Thank you.
Any other questions? So we do require the Constitution to be adjusted for us to go ahead and make this happen. So if you're not happy to approve the new name of South Warwickshire University NHS Foundation Trust, please raise a digital hand. Okay, I can't see any raised hands, so we're going to be changing our name. Thank you very much, colleagues. We'll then move on, and I do think that is an exciting development for the trust, for colleagues, and for the future. To have an association with the university in the way we have, I think, gives an exciting new chapter for things going forwards. So we're on then to the draft quality report. Ellie, over to you.
It's actually Emma Ratley who's here for this.
Good afternoon. Thank you very much. Thanks, Ellie. Thank you. So yes, that's okay. Yeah, the draft version of the 21-22 quality reports being submitted for consideration and comments to the Council of Governors. Quality reports are no longer required as part of the NHS Foundation Trust's annual report, as outlined in the NHS Foundation Trust annual reporting manual for 21-22. Relevant matters can be incorporated directly into the annual report. However, Swift has chosen to provide a full quality report as in previous years, which will be appended in full to the Trust's annual report. Quality accounts are an important way for local NHS services to report on quality and show improvements in the services they deliver to local communities and stakeholders. The quality of the services are measured by looking at patient safety, the effectiveness of treatment patients perceive and receive, and patients' feedback about the care provided. The quality report is set out in 3 parts. Part 1, the statement of quality from the Chief Executive. Part 2, priorities for improvement and statements of assurance from the board, which includes performance against quality priorities and indicators. And Part 3, which is any other information, and then 2 annexes, which include statements from local stakeholders, namely our CCG, Health Watch Warwickshire, and Overview and Scrutiny Committee. These have been requested but not yet received, and so they'll be added to the final report once received. And then lastly, statement of director responsibilities of the quality report. The document is lengthy due to what was previously statutory reporting requirements, and Swift has continued to report on these for consistency, transparency, and to provide assurance to all those who read it. So yes, it's long, but I hope you've taken some assurance from reading it, and thank you very much.
No, thank you, Emma. It is a Herculean task pulling this together, so thank you very much for doing a great job again, as Glenn said. So this is just for comment. Any comments from governors? Roger?
An excellent report. Yes, it's hard work reading that length, but I would commend it to people, particularly to new governors and those who are wanting to know what Swift actually gets up to, because amongst other things, it contains a number of organograms, which are very useful and explain an awful lot. Well done. It's excellent. It's an excellent job and shows just why we should be very grateful to Glenn and Russell for their leadership and the hard work of all the staff, despite the obstacles that have been around in the last couple of years.
Thank you, Roger. Any other questions or perspectives? So we look forward to seeing the final version with all the I's dotted and T's crossed. But like I said, thank you very much for your hard work.
Thank you.
So we move on to the Council of Governors schedule of business. Meg?
Thank you, Russell. Yes, this is the schedule of business for 22-23 and is based on the previous schedule of business, just refreshed and updated. So that's for the council's consideration and approval, please.
Okay, great, thank you. So I think this is pretty straightforward. Any questions from colleagues on the annual schedule of business? Okay, so we'll move on. Thank you. And that's approved, Meg, to the General Purposes Committee, the 30th of March. Mary?
Thanks, Russell. Well, I take it that the minutes have been read. So I just want to briefly just say that it was business as usual with setting the agenda for the Council of Governors and the training programme for pre-COG meetings. We also looked at the roundtable programme. The Membership and Engagement Committee is still on hold, waiting in the engagement strategy, and that will keep appearing on the GPC agenda until we get that sort of issue resolved. We had a long list of ideas for training, which we want to put into a training programme. The volunteer services was popular, so we've already mentioned in the pre-meeting we're having a volunteer service. Sharon's doing a presentation sometime in coming weeks. And we're thinking we might have training sessions in between the Council of Governors to get more training provided. And members suggested that the annual members meeting could include the Trust's research agenda and the digital healthcare at home agenda. We had a presentation today from the Digital Hub team, which was really enlightening, and we're going to do some more. But it was very much business as usual for general purposes, but I'm happy to take any questions.
Thank you, Mary. Any questions or perspectives to the GPT? Okay, thank you for your role as lead governor, Mary. I know it takes up a lot of time behind the scenes, so it's greatly appreciated. Then I think we've had a patient care committee meeting. The update on that, please.
Yeah, that'll be me again. Yes, we actually had one. Excuse me, had one on Monday. It was the first one for 6 months. I think the last one was in September last year. Unfortunately, because it was only on Monday, the team haven't had a chance to produce any minutes yet. So I'll give a very brief report. As the outgoing chair, Richard, was no longer there, Sharon Ellswood kindly stood in and chaired the meeting on Monday. But in her absence, we appointed Jean as the substantive chair. So thank you, Jean, for taking on the role of patient care committee, which is a commitment because she also sits on the clinical governance committee. And now that we've decided that the patient care committee will meet every 4 weeks, it'll be a 4 weekly patient care committee and a 4 weekly clinical governance committee. So thank you, Jean. There was a couple of issues that were held over from previous meetings. One included pharmacy issues and one was patient-initiated follow-up. So we will put those on the next agenda. I outlined the pilot of pharmacy technicians on wards, which Jean's already alluded to from the Safer Discharge group. And Ellie outlined a scheme where they have already a specialist nurse who's available to speak to patients after discharge instead of them having a follow-up appointment. So this is a sort of initiative along the lines of patient-initiated follow-up. David, the chair of clinical governance, informed members that the clinical governance committee was assured of safe care. And we did have 7 clinical governance reports on the table because we hadn't met for 6 months, so we couldn't really do justice to all the reports. But the main concerns that David highlighted were staffing as the biggest risk and children in crisis. Questions that were asked included improvement on the WHO checklist, the charity funding for chaplain for paediatrics, the Ockenden report, and staffing levels. Assurance was given that the clinical governance committee follow up outstanding serious incidents, because some have been on the list for a long time, and that we do have an open culture and the incidents are reported and complaints are reviewed. A full strategy is being reviewed and will be reaching out to community and to care homes, and it's acknowledged that there needs to be a partnership between acute, community and social care in falls prevention. It was acknowledged that performance hadn't been as it was in the past and as we would have liked it to be, but that we're all fully aware of the pressures that have been around in recent times, and that acknowledge the hard work of our staff in very difficult circumstances and that they're exhausted. But staff members pointed out that they are very happy for issues to be raised, and if governors don't raise issues, then we don't get the learning. So I think it's raising the appropriate issues in the appropriate way. Patient Forum gave their usual update, and they're very keen to get back out on the wards as soon as it's safe to do so. Volunteer Services gave a report, and we've talked about the training. Members unanimously agreed that we would change the format of the meetings and have meetings every 4 weeks in a rotation, so that we have clinical governance meets, the clinical governance papers go to board, and then the following Monday, the patient care committee meets, so they've got fresh, up-to-date data that has just been to board. So the terms of reference for the patient care committee will come to the next meeting. They need to be reviewed to reflect these changes. And so we'll have to ask Meg that they're not updated at the moment, but we take them back to our June meeting. Thanks very much. Any questions?
No, thank you, Mary. Any questions to Mary? We have a hand raised by Jean.
The reason I wondered about the agency, obviously that's very important to patient care and everything else. Whether, I mean, I know how good you are and our arm's length people in bringing in new initiatives. And I thought in the past that, I know we've probably got a bank. I mean, Ellie will know all about that. But I would have thought we ought to have our own agency company, so that it's really important that you get continuity when you have agency nurses on your ward, because they can vary in terms of capability and experience. And so if we had our own agency, presumably that would cut some of the costs, and it would also ensure that we'd had continuity in terms of their quality of care.
Jean, this is an active discussion in the board, obviously, with the bank. Glenn, do you want to come in?
Yeah, I'll try and give it a quick answer, as you suggest, Russell. It's a big area. I mean, we discussed, we looked at the business case a month or so ago, a board actually around improving our recruitment and retention strategy alongside some changes to the way that we run the bank. And investing more manpower into coordinating the bank. And the bank should be the same as an agency, Jean. And I think actually one of the things that Russell and I found when we went into Wye Valley is that they've got their own agency. And it got to the situation where working for an agency appeared to be all right, because there was a trust one and there was another one and another one. I would rather make it clear that we don't want agency staff. We want bank staff or substantive staff. And the way to do those extra flexible hours is to be on our bank. But we're strengthening it, but also recruiting and doing some international nurse recruitment as well. So you'll see more on that over the coming year.
Thanks, Glenn. Thanks, Jean. Any other questions to Mary? Okay, so I think the Business Oversight Committee hasn't met, and it's been discussed, I know, by governors. The report on resignation and appointment to governors then, please, Meg.
That's just submitted for receipt and noting, please.
Thank you. Any questions on that report? So I think we're on to any other business. Any other business from colleagues? Just from me, just to reiterate what I said at the start, was immense thanks to Meg for her 15 years, I think, of service to Swift and holding us by the hand to become a foundation trust. And the second was there are actually just under 42,000 people who have signed up for the patient portal, which I think is incredibly successful. I'm sure there are issues with it, but that level of take up, I think, is extraordinary. Any questions from governors? Roger?
Yes, Russell. We hear a lot in the press about delays in ambulance handovers and managing patients while they are in the ambulances waiting for that. How is, bearing in mind that there doesn't seem to be a great deal of space behind A&E, and I wonder how we've actually managed this problem in both aspects.
Harkamel, you want to go to Harkamel first?
Yeah, we're actually managing that really well. So it is a challenge for us. And in the past week, I think we've had 2 ambulances that have waited over the hour, which is obviously not ideal, but we are by no means seeing what some of our colleagues in the rest of the Midlands are seeing. In terms of how we manage it, we've tried to, the way that we have placed the ambulances and managed that throughput, we've changed that slightly so that they all come in and hand over to a slightly different space. It's slightly less crowded, so you can kind of bring the trolleys in a little bit easier, and there's greater visibility in terms of from like the ED department themselves. We also, Glenn and I get an email on the hour every hour to tell us how many ambulances are waiting, not only at our trust, but also across the region. So if at any one point it looks like any of our neighbouring organisations are struggling, then I'll know straight away that there's a potential risk to us here in terms of conveyancing here. So I'll cascade that message through. So from our point of view, we're not seeing some of those really, really long delays that we're hearing about in the press.
Thank you very much.
Excellent.
Thank you, Harkewell. Glenn, did you want to come in on that point? Then I'll go to Sue.
Harkewell covered it really well. I was just going to give you so right now there are 85 ambulances waiting outside hospitals in the Midlands. There are a further 28 on their way to hospitals in the Midlands. We have one waiting outside, you wouldn't want to be in the Princess Royal or Worcester Royal because they're the ones with the longest waits at the moment.
Yeah, but things change and things don't change. Sue.
Sorry, it's a very quick follow-up from the international nursing question. We recruit from countries that can ill afford to lose their nurses very often, and I was just thinking when I was working in doing some work within the RCN, our president actually sponsored, did some fundraising to sponsor nurses in India, and the money, it surprised me how little. That we're probably only talking £5,000 or £6,000 to train a nurse in India, and if we're taking their much needed nurses, and we do want to give people an opportunity to go abroad and to broaden their education and their experience, but is there anything we could do to work with these countries and actually fund some of that nursing to help them recruit more nurses and train them?
I think that's a really good challenge, Sue, and it is a big topic. I have felt for a long while that there is something a bit morally questionable about taking nurses from countries where mortality rates are high and encouraging them to come to the NHS. So can I ask Glenn and I take, rather than give a quick reply, so take that point away. Glenn and I are talking about another topic which Jane has raised with us on the ways we can help underdeveloped healthcare countries, but it's a great question which requires a properly considered response rather than a short one. No. But I agree with you, so it is not a situation that I think any of us should be feeling proud about. There's a difference between someone wanting to come to this country and bring their skills compared with going out and very positively encouraging them to leave a healthcare system which is in desperate need of their skills anyway.
Yeah. Sorry, could I just come back, Russell? I was only thinking that, yes, we wouldn't want anyone to come who wasn't absolutely passionate about coming, but maybe we'd be able to backfill those people who did come.
Yeah, I understand the point. So, Helena?
I just wanted to say Happy Nurses Day for everybody, because today's obviously Happy Nurses Day across everywhere. A question that some of my colleagues have been asking is, and we haven't really had an answer for yet, is the staff boosters, because obviously age groups have been had their fourth boosters like my parents have, whatever, but I just wanted to ask about the staff boosters. Are they going to be linked with the flu jabs, or that's one question? And also just a note that we've had a really increase in lots of palliative and end of life patients, lots of admission prevention patients, and this sort of rapid home to die patients that are end of life. And unfortunately, we haven't always been able to actually successfully had their preferred place of death because of our capacity issues, high staff sickness, which has been quite a tragic, really. But just to sort of wanted to ask those questions and just to note that about the end of life, really.
No, duly noted, Helen. I think the whole system is stressed by the level of absences that we're suffering. But on that first point, Glenn?
Yeah, I've not seen the final confirmation of it, but yes, there will be boosters. Whether we can do a combined flu and COVID booster, I think the jury's still out unless Eddie knows any more on it. But obviously,
There's no reason why you can't have both at the same time. I had my last ones. I had one in each arm at the same time.
Yeah, it was whether they could combine it into one was still
No.
the debate going
I think
on.
we're still waiting to see.
I know we've started our sort of flu training campaign a little bit early now, kind of just wanted to try and make sure everyone's up to date with their peer flu training in preparation. So whether we could use our peer flu vaccinators in the same way in teams locally to try and get a bit of a better uptake on the boosters as well. I don't know, that could be one idea.
Absolutely, but we certainly will need to ensure that health and care workers do get a booster for the coming winter.
Okay, thank you.
Thank you, Helena. Okay, if there are no other questions, I don't think we've got any questions from members of the public, have we, Meg? I don't think we've got any members of the public on the line either.
No, we haven't, thanks, Russell, no.
Okay, so our next meeting is on the 8th of September. And I suggest what we now do is have a 5-minute comfort break, and then we'll go into the confidential bill. So 5-minute comfort break, and I'll see you shortly.